All right, let's dive into a topic that's, well, really important for women's health. We're talking about understanding a specific type of cancer today.
That's right. We're doing a deep dive into endometrial cancer. You might also hear it called uterine cancer. Same thing, really. It affects the lining of the uterus.
And we have some source material, some notes, essentially, from a listener who wanted to get a clearer picture of this.
So our job today is to unpack those notes, pull out the really crucial insights and facts about endometrial cancer.
Exactly. We'll try to cover what the notes lay out, what it is, the risk factors, how it presents itself, how doctors find it, the staging, treatment, the whole picture, basically, straight from the info we were given.
Yeah, it's definitely a topic where getting a good handle on the details can really help. We want to make the key takeaways from these notes super clear for you.
Okay, so first things first, what exactly is endometrial cancer? Where does it start?
So basically, it's a malignant tumor cancer starting in the endometrium. That's the inner lining of the uterus.
And the sources say it's pretty common.
Yeah, actually the most common gynecological cancer, according to these notes, and fifth most common cancer in women overall. So significant.
Fifth. Wow. Okay. And who does it mainly affect? Is there a typical profile?
Well, the vast majority, the notes say over 90% happen in women who are postmenopausal.
Okay.
The sort of average age at diagnosis is around 63. But, and this is important, the sources stress it can affect premenopausal women too. It's just less common.
Right. So mainly postmenopause, but not always. Are all these cancers the same, or are there different types we should know about?
Ah, good question.
Yeah.
The notes make a key distinction here. About 90% are a type called adenocarcinoma, but they generally fall into two main buckets, type I and type 2.
Type I and type 2. Okay, break that down for us.
Sure. So type I is the more common one. It's often linked to having too much estrogen around, relatively speaking.
Okay.
The notes say it usually develops from a sort of precancerous state called atypical hyperplasia. Basically, the lining gets too thick and the cells look abnormal.
And the prognosis for type 1?
Generally better. That's a really important point from the courses. They tend to be less aggressive.
Got it. And type 2?
Type 2 is less frequent, maybe 10% or so. The sources describe this one as being less connected to estrogen. Sometimes it actually arises from a very thin atrophic lining, which you might see after menopause.
And the difference in how they behave.
Big difference. Type 2 cancers tend to look more aggressive under the microscope, what doctors call high-grade histology. And sadly, they generally have a worse prognosis.
So where it starts, how the cells look, it really matters for the outcome.
Absolutely. That type I versus type 2 difference is a major theme in the notes, and something else comes up again and again.
Which is?
Early detection. The sources are really clear on this. Finding endometrial cancer early, when it's just in the uterus, that's critical for a good outcome. Makes a huge difference.
That makes total sense. Catch it before it spreads. Okay, so we know what it is, the types. Why does it happen? What causes it? The notes say the exact cause isn't nailed down.
Right, it's usually a mix of factors, not just one thing. But the biggest factor highlighted in the sources seems to be hormonal imbalance. Specifically, too much estrogen compared to progesterone. They call it unopposed estrogen.
Unopposed estrogen. So anything that kind of tips that balance towards more estrogen could increase risk.
Pretty much, yeah. And the sources list several things that fit that idea, or just known risks. Age, definitely. Being over 50, especially postmenopause. Obesity is a big one.
Why obesity?
Well, body fat can actually produce estrogen, so more fat can mean higher estrogen levels, which ties back to that unopposed estrogen idea.
Ah, okay. What else is on the risk list from the sources?
Other hormonal things,
Mm-hmm.
like taking hormone therapy that's just estrogen without enough progesterone to balance it.
Right.
Conditions like PCOS, polycystic ovarian syndrome, which can mess with hormone balance. Also, things related to lifetime estrogen exposure.
Yeah.
Starting periods very young, going through menopause late, say after 52, or never having given birth, nulliparity.
Any medical conditions or specific drugs mentioned?
Yeah. Diabetes is listed as a risk factor. And tamoxifen, a drug used for breast cancer, it can act like estrogen on the uterus, so that increases risk too. And of course, that precancerous thing we mentioned, endometrial hyperplasia.
Okay. What about genetics? Does family history play a role?
It definitely can. If you have a family history of endometrial or even colorectal cancer, the risk is higher. The sources specifically mention HNPCC or Lynch syndrome.
Lynch syndrome, right.
Yeah, that's a genetic condition that really bumps up the risk for several cancers, including this one. One source even mentioned a possible link to BRCA mutations, BRCA1 and 2, though they're more known for breast and ovarian cancer.
Wow. Okay. So it's quite a mixed age, hormones, weight, medical history, genetics. It's a lot to take in. Is there anything that actually lowers the risk?
Yes. Interestingly, the notes point out that using combined oral contraceptives, the pill seems to offer some protection later in life. It actually reduces the risk.
Huh. That's a good counterpoint to know. Okay, so stepping back, how does this all happen on a cellular level? The pathophysiology.
So the sources describe it, starting with genetic changes, mutations in the cells of the endometrium. These mistakes basically tell the cells to grow and divide uncontrollably.
And that forms the tumor.
Exactly. That uncontrolled growth builds up into a tumor in the uterine lining. And if it keeps going, it can invade deeper into the muscle of the uterus, spread nearby.
And eventually metastasize.
Right. In the later stages, it can travel to other parts of the body. The sources also mention that the different subtypes, like type I and II, have their own specific genetic drivers, which helps explain why they behave differently.
Got it. So if someone has symptoms, what else might be going on? What's the differential diagnosis?
Good point. The notes list things doctors need to consider. Endometrial hyperplasia, that precancerous stage, is a big one. Causes similar bleeding.
Okay.
Uterine fibroids, they're benign, not cancerous, but can cause heavy bleeding too.
And potentially other cancers nearby?
Yeah, the sources say cervical cancer and ovarian cancer need to be ruled out, as symptoms can sometimes overlap.
Okay. Let's zoom out again to the epidemiology, the bigger picture.
So like we said, age is key. Over 90% of cases in women, over 50, median age 63. The UK data in the notes puts it as the fourth most common cancer in women there, about 8,600 new cases a year.
It's quite a few, and the sources mention the numbers are going up.
Yes, that's a really important trend highlighted. The incidence is rising, and the notes link this mainly to two things: rising obesity rates and the fact that populations are aging. More people living longer means more people reaching the main risk age group.
That obesity link keeps coming up.
It does. And geographically, it's noted as more common in Western countries, but also increasing in Asia now, too.
Okay, so let's talk symptoms. How would someone know? What are the clinical features? This feels really crucial.
It absolutely is. And the sources are unanimous on the #1 absolute hallmark symptom: postmenopausal bleeding. PMB. Any bleeding at all from the vagina after menopause.
Any bleed?
Any bleeding. The stats in the notes are stark. 91% of women with endometrial cancer have PMB. And if a woman has PMB, there's roughly a 9% chance it's due to endometrial cancer.
9%. That's not insignificant. So PMB is always a must-investigate situation.
Always. The sources couldn't be clearer. You have to rule out cancer. Now, for women who haven't hit menopause yet, the signs are more about changes in bleeding patterns.
Like what?
Irregular periods, bleeding between periods, maybe suddenly much heavier periods than usual. Things like that listed in the notes.
Are there other symptoms, maybe less common ones?
Yes, especially as things advance. Pelvic pain, maybe feeling a lump or mass down there. Unexplained weight loss, being really tired all the time, leg swelling.
Yeah.
Those can happen.
Okay.
And if the cancer is spread widely, you might get more general symptoms like abdominal swelling or discomfort, shortness of breath, that kind of thing. The notes add that a physical exam often doesn't show much unless it's advanced, but a recent cervical smear is usually checked. Got it. PMB is the big one, but other changes matter too. So, someone has symptoms. How do doctors figure it out? What are the investigations the notes describe?
Okay, the typical pathway starts with a transvaginal ultrasound, or TVUS, especially for postmenopausal bleeding.
And what does the TVUS look for?
It measures the thickness of the endometrium, that uterine lining. If it's thicker than expected, that raises a flag. It could be hyperplasia or it could be cancer.
Is there a specific thickness threshold?
The notes mention a 3 mm cutoff is very sensitive, good at catching potential issues. Some places might use 4 mm or 5 mm as the trigger for the next step. Basically, the ultrasound helps decide who needs more tests.
And what is that next step, usually?
An endometrial biopsy. That's how you get the definitive diagnosis. A tiny sample of the lining is taken and looked at under a microscope histology.
How do they get the sample?
Often during a procedure called hysteroscopy. This is where they use a thin scope with a camera to look directly inside the uterus.
Ah, right. You mentioned that earlier. Exactly. It lets them see any polyps, fibroids, or suspicious areas, and they can take a targeted biopsy right then and there. The notes say hysteroscopy is very accurate for diagnosis, though they do caution that even with sampling, very small cancers can occasionally be missed.
Are there other tests doctors might use?
Sure, a physical exam is standard. Sometimes blood tests like CA-125, though it's not specific for this cancer. And if cancer is diagnosed, then imaging like CT scans or chest x-rays come in. That's for staging, figuring out how far it's spread.
Staging. That sounds really important for deciding on treatment, right? How does that work?
Yes, crucial. The sources refer to the FIGO staging system. It basically describes the spread. Stage 1, just in the uterus body.
Okay.
Stage 2, spread down into the cervix, but still within the uterus overall. Stage 3, spread outside the uterus, but still within the pelvis or nearby lymph nodes. And Stage 4, spread further, like to the bladder, bowel, or distant organs, lungs, liver, bones.
And there's grading to different levels of aggressiveness.
Yep. Tumor grading. G1, G2, G3. It's based on how abnormal the cells look compared to normal endometrial cells. G3 is high grade, meaning more aggressive, generally a worse prognosis than low-grade G1.
You know, one point in the sources really stood out about diagnosis timing.
The fact that it's often diagnosed late?
Yeah, despite having such a good prognosis if caught early.
Exactly. The notes explicitly state it's often found at stage 3 or 4, which just hammers home why paying attention to symptoms, especially PMB, and getting checked out quickly is so incredibly important. Stage I is highly curable.
That really highlights the awareness gap, doesn't it? Okay, so once it's diagnosed and staged, how is it managed? What do the sources say about treatment?
Well, the main message is treatment depends heavily on the stage, and it's tailored. But surgery is usually the cornerstone.
What kind of surgery?
For early stage, like stage 1, the standard is usually a total hysterectomy, removing the uterus, plus removing both tubes and ovaries. Bilateral salpingo-oophorectomy, BSO.
Okay, and for stage 2?
It's typically a more extensive surgery, a radical hysterectomy, and often includes removing pelvic lymph nodes to check for spread there, lymphadenectomy.
And for the later stages, 3 or 4?
That usually involves a combination approach. Often surgery to remove as much tumor as possible, called debulking plus radiation and chemotherapy.
Are there other options besides major open surgery?
Yes, definitely. The sources mentioned laparoscopic or keyhole. Surgery is used more and more. Studies show survival is just as good, but recovery is often easier for the patient.
What about radiation?
Radiation is used quite a bit, sometimes after surgery to lower the chance of it coming back, sometimes if surgery isn't possible. And it's standard treatment if the cancer recurs locally, like in the vagina.
And drug treatments? Hormones? Chemo?
Yep. Hormone therapy drugs that block or lower estrogen can be used sometimes. Chemotherapy, usually platinum-based drugs, is mainly for advanced or recurrent cancer, or sometimes given after surgery, adjuvant chemo, where the notes say there's moderate evidence it can slightly improve survival.
What about younger women who might want to have children?
Yes. The sources mention progestogen therapy, using progesterone-like hormones as a potential option to try and preserve fertility in very specific, carefully chosen cases of early-stage, low-grade endometrioid cancer, which is a type I. It's also sometimes used for older patients who aren't fit for surgery.
Any newer treatments mentioned?
There was one specific combo highlighted, pembrolizumab with lenvatinib. The notes say this is recommended for advanced or recurrent cases after platinum chemo, where cure isn't possible with surgery or radiation.
Sound like putting together a treatment plan is quite involved.
Absolutely. The notes stress the importance of a multidisciplinary team. Gynecologists, oncologists, radiologists, pathologists, all working together to figure out the best plan for each person, considering everything: stage, grade, cancer type, overall health, and patient preferences, like fertility.
Okay, so after all that diagnosis, staging, treatment, what's the outlook? What do the sources say about prognosis?
Well, again, it really comes back to early diagnosis. Prognosis is much, much better if it's caught early. And if it does recur, the notes say it often happens within the first 3 years.
What about survival rates?
For early stage, really good. The sources say about 80% of women with stage I are cured just with surgery. The 5-year survival for early stage is over 95%.
That's fantastic news for early detection.
It really is. But the numbers drop off sharply with spread. Regional spread, stage 3. The 5-year survival is around 68%. Distance spread, stage 4, it's down to about 17%.
Wow, that's a huge difference.
It is. Overall, looking at everyone, the 20-year survival is around 80%. But the sources also point out lower survival for some specific subtypes, often the type 2s like clear cell or papillary cancers, reinforcing that the type matters too.
Any other factors affecting prognosis mentioned?
Yes, BMI. The notes link higher BMI to higher overall mortality rates in patients, even after treatment.
And lastly, what about potential complications from the cancer or treatment?
The main ones highlighted are metastasis, the cancer spreading and recurrence, the cancer coming back,
And from the treatment itself.
Well, the big one from surgery is infertility, obviously, from removing the uterus. And if the ovaries are removed too, that triggers surgical menopause.
Right. Well, we've certainly covered a lot of ground, pulling out the key details from these notes. We went from the definition, the types, all those risk factors, how it develops, the symptoms, especially PMB, then diagnosis, staging, the treatments, prognosis, complications.
And the recurring theme from the sources, the absolute critical importance of early detection, recognizing symptoms, especially postmenopausal bleeding, and acting on it quickly. That's the take-home message.
Absolutely. Having this information pulled together from the source material like this, it really is empowering for you, the listener. It helps you understand the risks, what to look out for, and why getting checked is so vital.
Yeah.
So as we finish up, maybe something to think about, drawing from what we've discussed based on these notes. That rising incidence linked to obesity and aging. What does that mean for public health down the line? Or even for your own health awareness? And then consider that huge difference in survival, over 95% for stage I versus 17% for stage 4. Doesn't that just underscore everything about needing to catch this early? It really puts the value of prompt investigation into sharp focus.
Precisely. Seeing those connections and implications in the data, that's why digging into this kind of material is so worthwhile.